Hi, everyone. I'm Emily.
And this is Eva.
And you're listening to Speech Talk.
We're your research book club so you can do evidence-based practice in practice.
So let's start talking. Eva, tell me about your week this week.
Oh, everyone got sick for the second week in a row. So honestly, the best part of my week is this right now. I'm so excited for our episode. Oh, and we're celebrating season 2 of this episode. Emily, we've been doing this for a year.
That is so wild. And we need like poo-poo, confetti.
Confetti cannon, t-shirt cannon, balloons falling from the ceiling, all of those feelings.
It is really crazy to think about like this being our season 2 because we've been like behind the scenes working on this for even, like when did we start?
Longer.
January.
We started 2 years ago.
Yeah.
We just wrote episodes for like a year and tried to do some research and development in terms of how we thought people would like it with our friends. No one listened.
And our friends don't listen. Our one friend texts us in a group chat and says, "Hey guys, I'm thinking about potentially switching over to the Sniff Life. You got any tips?" Like, yeah, listen to our podcast. Like, there's a bunch in there. Any episode, take a pick.
So yeah, that's pretty big. And how about you, Emily? What happened this week that was big? Fun.
Well, for starters, also, we have been sick over here. I didn't know that you couldn't, like, it's not a thing all the time that strep throat goes away with one bout of amoxicillin. So I'm on my second round of antibiotics. But you know what? I got 2 days off of work for it.
You know, you're feeling real burned out at work when you're like, oh man, I'm sick. I can stay home.
I am highly contagious. Don't talk to me.
That's terrible. So sorry you're on your second round there. Rough stuff.
Yeah, rough stuff. So if my voice sounds weird, that's why.
And when you guys hear me blow my nose, there we go. Okay. So part of the reason I'm so giggly is I'm so excited to talk about his episode. I really went down the research rabbit hole, but I've reeled it in. And I'm going to start off with asking you a question. Emily, do you ever feel like you're fighting your patients to do speech therapy?
Real talk, if I have to fight them more than twice, we start educating on discharge. Like, you may need this, like, the grass needs sun and earth. But if you are just like, meh, girl, me too. Like, I don't care either. If you don't want it, then that's perfectly fine.
Yes. And I hate that feeling of being like, why am I fighting you to do speech therapy? It always makes me feel like I'm doing something wrong because therapy is supposedly helpful. And instead, people are telling me that this isn't helping. They don't think they have an impairment. They won't do their strategies unless I'm standing over them aggressively. And I was just like, I'm done. I'm done with this life. And I was listening to this other podcast, How to Be Patient, and they have an episode on, it's called Acceptance and Commitment Therapy. And I was like, oh my God, maybe this is it. My patients aren't in the space to do therapy because they haven't even accepted where they're at. And that's kind of what sent me into this internet spiral on speech therapy and acceptance and commitment therapy.
Wow, Eva, I'm intrigued because yes, my patients have not accepted where they are. Holy cow. How many times have you gone into a patient's room and they're like, yeah, I'm going to start walking again. And they've been bedbound for years.
I think you mean like how many times a day do I hear that? I don't have memory problems. Okay, where are you? I'm at home. No, you're in the hospital.
Right.
Yeah, you got memory problems.
And like to your other point, we just recently got a survey back about the helpfulness of therapy. And all the comment said was, speech therapy isn't as helpful as other therapies. It's
Right.
like,
And
ouch.
it feels like a knife in the back every time. And so then I started having like this other kind of meta thought about this, which is maybe I haven't accepted that they haven't accepted. And I need acceptance and commitment therapy, or ACT.
Are you committed to this profession? Have you cried in your car enough?
Yeah. So that's why I wanted to call today's episode The River and the Rock, because of that saying, the river doesn't argue with the rock because the river just goes around it, you know? That's what I feel like I want to be doing with my patients. I just want to flow around the obstacles, and I want them to take in as much as they're willing to accept and keep moving. I'm done fighting the rocks. So today we are exploring acceptance and commitment therapy, ACT, not as psychotherapy, but just as a guiding framework for how we conduct speech therapy.
So before we jump into today's articles, Eva, I think you should explain what ACT is.
Okay, so ACT therapy is a part of CBT therapy, or cognitive behavioral therapy. The underlying premise of CBT is that our thoughts influence our emotions and subsequently our behaviors. By intentionally, like very directly identifying and restructuring our distorted, or like unhelpful thoughts, we can improve how we feel and how we act.
Have you watched the Olympics at all?
Yes. Oakland in the house.
So Aline Gu was doing this interview, and one of the interviewers asked her if she even thinks before she speaks because everything comes off so eloquent in their words. And she said that she spends so much time in her own brain, structuring how she thinks and making sure she's thinking positively. So that's what you just reminded me of. She makes herself think positively, and so she is positive. She makes herself think winning thoughts, and so she is winning.
I love that. And yes, that is a lot of the essence of it. You're like, you can restructure how you think about things if you do it intentionally.
It was a funny way the reporter asked, but do you even think before you speak? Like, no.
Do you even think about your words? No? Okay.
So in our patient world, if a patient says, I'll never get better.
Yeah, exactly. We want them to examine and challenge that thought and be like, well, you may not get to where you were pre-stroke, but you can definitely get better from where you are. The statement, I'll never get better, that's just a huge statement to make. And in a lot of ways, it's just empirically false. You're going to make gains.
Yeah. So what about ACT?
Yeah. So where CBT is trying to restructure your negative thoughts, ACT assumes that difficult thoughts and emotions are just like part of being human. Like that's part of our lived experience, but that we can change our relationship to our thoughts and feelings. So the negative experience is there, but we can change how we feel about a negative feeling.
So that would look like a patient saying, I'll never get better, but then the therapist doesn't argue with it. You just acknowledge and kind of try to move forward.
Yeah, exactly. And I've actually done CBT therapy for myself in my 20s when I had a lot of early 20s depression, and I found it really helpful. But I think as a clinician, I like that ACT framework because I don't feel comfortable telling my patients, hey, your thoughts aren't true. Like that does not feel like my place. On the other hand, I do feel comfortable acknowledging their feelings and trying to help them keep moving towards their goals.
So in speech therapy, we're constantly asking patients to do things they are uncomfortable with. We're trying to get them to eat differently, speak differently, use strategies, slow down, stop between words, open your mouth wider, practice.
Yeah. And we're like asking them to be imperfect in public, and that's so hard. And even asking them sometimes to acknowledge that they have an impairment is hard, especially if they have like anosognosia and they're like, I can stand. And you're like, you have bilateral leg impairments, you cannot stand, my friend. So sometimes just acknowledging the impairment is really difficult.
Okay. I think I get it. time for some research. And let's do some acceptance and commitment therapy practice.
I know. I feel like we're about to do some like real wedding or marriage counseling for the two of us.
Aw, that'd be so cute.
Oh, our acceptance and commitment therapy to each other.
I commit my life to you in this
wives.
podcast.
Yeah, exactly. Okay, so I really did try to limit the number of things I looked into for today's episode, and I kept it to 3 things, 2 articles and a CEU. The first article was Group Acceptance and Commitment Therapy for Post-Stroke Depression. Second one was Adapting ACT to Stroke Survivors with Aphasia. And the last was a speechpathology.com CEU called ACT Framework.
Was it free?
I have an account with them, so I actually don't know if it's free straight up. All right, quick pause. We'll be back right after this break.
Okay, so you may ask, why are we looking at therapy models for speech work? But remember, clinicians do have counseling as a component within our scope of practice, so understanding a particular way to approach counseling is something we wanted to get into for this.
Yeah, and especially since I oftentimes do not feel qualified to do the counseling aspect, it was nice to kind of see this principle at work. All right, Article 1 was a randomized controlled trial looking at post-stroke depression in patients who received group-based ACT therapy. The study found that ACT interventions significantly reduced depressive symptoms at follow-up check-ins compared to the usual stroke care patients, even when a patient's neurological impairment didn't change.
So they're feeling better without necessarily getting better?
Yeah, exactly. People are feeling better about how they're doing post-stroke without necessarily having significant neurological improvement. The results seem to suggest that increasing a patient's psychological flexibility can improve their emotional adjustment during recovery. And what's important for us as clinicians is that the research demonstrates that ACT can be done within the medical rehab setting with like meaningful impact on patient well-being. The study findings really show the role of emotional processes in engagement and recovery.
That's really cool because normally in medical settings, it feels more emotionally heavy, right? Like a lot of times this can be someone's very first run-in with a stroke and it has been debilitating, right? Like it has really knocked them on their butt. Like this is a whole new change. We've gone from running daily to bed or wheelchair bound. So just being able to talk about some of the things in our scope that is a little bit more hard, but maybe is workaroundable, and not really, and the patient might not be giving that their highest focus, gives them a good opportunity to vent out those psychological and emotional changes in their speech therapy sessions.
Definitely. And your point about like, this is a heavy place to exist. You've just gone through a big change. It's also like when you're in the hospital, you might have your own room. In a SNF, you might be sharing it with like 1 to 4 other people. You're not sleeping well. You got none of the comforts at home. Like this is not really usually a place that I associate with like emotional healing.
Right.
So it's nice to know that by having targeted acceptance commitment therapy, you can see improvements. This research specifically looked at group sessions where the researcher said patients could socialize with similar experienced peers, provide opportunities for altruism, and that it was cost effective. And I just wanted to see what you thought about that idea because I've had really limited access to group sessions, but you are like the queen of group therapy.
Not the queen, but
Maybe the princess?
I'm the jester of speech of group therapy. So the groups that I've watched seem so supportive back and forth. And then I've had groups where people have volunteered information about their memory impairment and have been able to share that with each other. And it is really nice to see people bonding and talking about things that impact them together just by putting them in the same room and doing a craft or having a cookie.
Yeah, man. There was a stroke survivor volunteer at my hospital who comes in and talks with recent stroke survivors. And he and one of my patients were like just kind of chilling, talking about what it feels like to have uh, the sectioned skull from a craniotomy in your stomach. And they were just like kind of talking about it and like what it's like to have it sitting there, like waiting to go back into your head. And I was like, yeah, this is not a conversation that I could have started. Like, it really takes someone who's been through it to talk about it.
I'm so confused. What goes on with their stomach? They put it on their stomach for like safekeeping?
Oh, yeah. I recently learned about this, that sometimes in a craniotomy, when they take out a portion of the skull to relieve pressure on the brain, while they're waiting for the swelling to go down, they can't just like keep it on ice, but it turns out your body won't reject it. So they'll just like put it on your stomach for safekeeping.
Wild.
The quick Google search says removing a craniotomy. Oh, it's a craniectomy. There we go. A craniectomy involves removing a part of the skull to relieve severe brain swelling, with the bone flap temporarily stored under the skin in the abdomen to keep it sterile, nourished, and alive for future reattachment.
You learn something new every day. I'm shooketh.
I am shooketh. Yes. Anyways, it's pretty intense. And having those opportunities to talk about it seemed like it really was beneficial in an organic space, not like me being like, so tell me about the bone in your tummy. Tell me about that.
Do you still get ticklish in this spot?
Yeah. Let's go on to the second article. So the second article is actually a clinical trial that's still in progress, but I'm really excited about it because it specifically is looking at ACT therapy for the aphasia population. They've concluded the trial, but they haven't written their report yet. National Institute of Health Clinical Trials publishes their progress, so you can read what they're doing and their preliminary results as it's being done. The intervention modifies the language of traditional ACT techniques. It simplifies it to ensure that people with language impairments have good access.
So the study is looking at whether ACT can realistically work for people with aphasia, whether patients can participate in it, whether they can find it helpful, and whether it reduces emotional distress while improving real-world communication. It reinforces the idea that emotional adjustment and communication recovery go hand in hand.
And for us, it seems to suggest that ACT can be meaningfully integrated into speech therapy when adapted appropriately. And I'm so glad to see that somebody is trying this out, because if a therapeutic process relies on people being able to express themselves well, then it would kind of cut out like a very large portion of our population.
When you're working with someone with aphasia, you can see on their face that they're upset or distressed and they want to talk about it, but it's just stuck. And I feel like sometimes my therapy is just practicing that script. My words are stuck. My words are stuck. And then trying to compensate.
Yeah, going back to the idea of group support and aphasia moments, I used to be a volunteer support for an aphasia art group. It was led by a stroke survivor, and she would be in the middle of explaining, and she'd just be like, "Word stuck," and then cuss like a sailor, and everyone just laughed. It was so awesome to see everyone just totally relating on the intense frustration of like, you're talking, you're showing, and like you cannot get around this phrase, and you're like, I want to say it and I can't. And it was just this beautiful moment. I'd never been in a space where watching someone struggle resulted in everyone laughing together.
Mm-hmm.
And at first I kind of felt uncomfortable because I was like, oh, I can't laugh at people, that wouldn't be right. But then as the longer I spent with the group, the more I realized like these were moments where people were relieving their stress. They were relieving their tension through laughter. And it really helped me to see how just saying I'm mad help people move through it. And that's kind of the point of what we're talking about right now. Anyways, the final thing we're looking at is the CEU, which was actually presented by the same guy doing the National Institute of Health trial. His name is William S. Evans, and way to go, Will. So in his CEU, he does a really good job explaining some of the key ideas within ACT, and I wanted to review them here because there are these concepts I think can really help us as clinicians or, frankly, in our personal lives. So let's get into them. Emily, can you read us some of the list?
Eva, I got the word, you get the definition. Ready?
Got it.
Here are the things we can recognize in our patients. First off, cognitive inflexibility.
That's when you're stuck or really rigid in your negative internal experience.
Next up, cognitive fusion.
That's when you're feeling really fused with your thoughts. They're real, they're true, like they are your existence.
And lastly, we have experiential avoidance.
This is when you're trying to avoid or control or suppress an unwanted internal experience. And I don't know about you, Emily, but I have seen all of these in my sessions. People are like, I am never going to be able to, spend time with my family in the evenings when we're having dinner. And I'm like, what?
Yeah,
That's an absurd thing to say. Like, you'll just eat slightly different food. It's fine. And they're like, nope, it can't be done. You're like, oh, okay. So now we are inflexible. We are fused with this belief that like we cannot be someone who dines with our family. And then they start avoiding eating. And you're like, well, dang, you really entrenched yourself there.
Yeah. And we will link the CEU in the show notes so you can get a more thorough education on these three things via William S. Evans.
Yeah, thanks, Will. So if that's what we're seeing in our patients, we want to then look at what the ACT framework promotes to like kind of overcome them.
So first up, we have psychological flexibility. So almost the exact opposite of that first one. When we can open up, be present, and determine how we do what matters the most in that moment.
And so what is kind of component? As Emily said, there's open up, be present, and do what matters. Opening up therapy is being able to experience your negative or uncomfortable thoughts without putting up defensive mechanisms. For me, that reminds me of when I talk to my kids and I'm like, it's okay to be sad. It happens and we'll find something fun to do when it passes. Like, I'm not trying to tell you to not be sad. You're 3. It's going to happen.
Be present therapy. So experience what you're going through.
It's okay. Just live it. And do what matters therapy is ask your patients to identify their values. These are aspirations that help keep them moving forward. It's like, how do we show that we're a loving family member when our communication is impaired?
Yeah. And I feel like for this one, especially, I pull this kind of thing into all my treatments. I start off like, what are we working on today? What is your biggest hurdle? So we are actively trying to do what matters, keeping that ultimate goal in mind.
The hospital on the patient boards, it has goals. And a lot of people, it's like being able to walk, getting from my bed to my chair by myself. But I feel like so often it just says, go home.
Go home.
That's my goal.
Just go home. I don't care how.
Exactly. And then the last thing he talks about is workability. And from how I read this, it's kind of a sustainability metric. Like if what you're doing is making your life better, then yes, great, keep doing it. And if not, it's not workable long term. And we can help patients consider other more workable options. Let's take a look at what some of this might look like if we kind of used it with our patients. So I pulled together like a few little kind of case studies here, and they're just, I know, this is where I got really excited and nerdy. I just wanted to exemplify some of these concepts.
This is the first time I'm seeing.
Emily has not seen these, so my apologies. So I can't defend myself any further. I got real excited. And I hope, obviously I'm not a specialist in ACT, so I hope I'm doing the concept justice. I have to ask Evan Williams or William Evans if I did okay. All right, Emily, you be the patient. The cognitive change scenario. The patient who says, I don't need these strategies. What would an SLP say?
So you don't feel like you need this?
No, if that's what I said, I'm fine.
Okay. Would you be open to trying one small reminder today? Not because you have to, but just to see if it makes anything easier.
Exactly. So we're not trying to put them in the position of telling them their feelings they're wrong. If they say they don't need it, we're not telling them they do, but we're just kind of opening it and saying like, hey, what if it just made some things a little bit easier? Would you be open to that? Is that kind of just slight pivot to kind of not hit the rock river? We don't hit the rocks. We go around them. Okay. Last case study.
So if the patient shuts down and says, and this is an aphasia patient, the patient shuts down and says, I can't. Eva, what do you say?
I might look at them and just say, this feels really hard right now.
Yeah. The patient would agree.
Yeah, that makes sense. And we don't have to get it perfect. Let's just try something less intense. Would you be up for looking at maybe some family pictures on your phone or just doing something less structured? What might you want to do? And letting them kind of redirect the activity. We don't want to hit that wall. We want to go around it. Okay. I know I sprung a role play on you, but
I know. I don't know about that. That was the weirdest script.
If you were actually in the moment with some of those patients, how do you think that would feel trying that in a session with one of those patients who you're like, I am fighting you over therapy?
I definitely think that while I talk about having people come off my caseload if they fight me, you can definitely tell a difference between someone who is fighting you because, they hate it or they're not willing to accept it versus someone being just really frustrated and down about the situation. I think these situations, these specific scenarios, was the latter, right? Like in these specific situations, it's going to be a lot easier to open up your empathetic heart and your caregiver side and just be like, okay, like this is hard. Let's throw this away. Let's look at pictures of cats. And we're just going to talk about cats for a minute, or dogs, whatever your tea is. And I think in those situations where the patient is just combative and not really up for whatever you're trying to do, maybe they just really aren't ready. Those opening scenarios to me sound like such a good idea. And I'm sure it takes loads of practice to be able to diffuse those situations because
oh my God, yes.
even listening to this podcast now, like as we're talking about it, I'm like having a combative patient, like this feels hard and I'm not these patients don't exist. Like I'm stressed out about going into this session and it doesn't even exist.
Right. Because I think what you're pointing out is that these like tiny role plays, the following line the patient says is, no, I still don't want to do it. Like they're still arguing. To your point about the person who is, uncooperative versus like, I'm just having a hard time. And I think that brings us really well to my next part. The role play for us as clinicians.
Oh no, there's more role playing. Oh my God. I have to scroll more. What did you do, Eva?
I I got way too excited.
You're not allowed to have days off work anymore. What is it?
You sound like my husband.
This is why my internet is running slowly, is because our episode today is like 8 pages long, actually.
Okay, we'll tone this one down. But I think you bring up a really good point, which is that like sometimes you just literally cannot win with a patient, and those moments are so hard. But I think they drive us to something William Evans would point out, which is the avoidance aspect, that we're feeling rigid. Like, this is a rigid situation. I can't get out of it. This patient is hard to work with. I don't even want to go in the room. I hate this part of my day. Don't want to do this session. Like, these are all thoughts I've had about patients who were frankly mean to me.
Yes.
Well, not just mean, but like, you're just like really trying and they are just rejecting everything. You know that vibe.
Oh my gosh. No, honestly, there is a patient I have on caseload right now who anytime I ask him a question, he's like, what do you think? Like this huge attitude. He said I was a part of the KKK. I was like, actually offended.
Yeah,
I was like,
offensive.
how do I go back into this client's room who is struggling and help them if they're accusing me of being a Nazi? Like, I just said hello. You didn't like my tone.
It's how you said hello.
I don't know. Today I went into his room and his foot was hanging off the bed. I accidentally knocked into him twice and he reamed me a new butthole. Like, it was so bad. I was like, let me just turn around and leave. I'll never show my face in here again.
Oh, I'm sorry. That is really tough. That is a very hard situation to be in, especially since you have to go in there.
Says who?
And sometimes if a patient literally cannot engage in therapy, discharge is the right option. You're like, hey, you're not making progress. You're not engaged. It's no longer ethical for me to bill you because you're not making progress on your goals. And that's not on me, you know? We do always have that in our back pocket as like you know what? This isn't working out. Maybe outpatient is for them. Maybe this is something they're never going to engage with. And that's okay. And that's kind of the point of this next concept of like, how do we use an ACT check-in for us as therapy providers? So the first one I think we've kind of covered, which is like, notice the story your mind is telling you. Like, this is a waste of my time. They are too difficult. I don't want to do this. Then you can say, hey, I'm feeling frustrated. Maybe I feel like I'm not doing a good job. Then you move through, can I feel irritated and still be professional? Now we're separating like who we want to be as a clinician from what we're doing in the moment and like making that an active choice. This is us going from hitting the rock, who is the patient, because we never hit patients. We go around them.
It's a reminder to self. We never.
Reminder to self. So we move away from feeling like, hey, I'm telling myself I'm an incompetent clinician to, hey, I know I want to be calm and supportive and helping them, but I can't control that. What I can control is how I behave and what options I give them. And if I do those things where I remain calm and I give them new options and they still reject it, that's not about me. We're good. You know, this is the level of engagement they can do. That's just reality. You were the person you wanted to be in the room and you can feel good about that.
That's real, Eva. That's deep.
And now you see why I was a little obsessed with this concept.
Very obsessed. Because
like,
I mean, yeah, like, because it is so hard to try and make sure we're like keeping yourself in check, but you can be irritated and still act professionally. Sometimes have to take breaks and just say you're going to the bathroom or something and do a couple goose frabas and calm yourself down.
Don't know what that word is.
From anger management, Adam Sandler.
I do know about that movie. I don't think I've seen that one.
He makes him say goose for ba whenever he gets too mad.
Oh,
It's just the saying.
I
That's
like
how you
that.
calm
That's
yourself
good.
down. When
Oh,
someone's
Adam
stealing your
Sandler.
woman, you say goose for ba.
Or you write a country song. I won't take a shot at country music. But no, I like what you're saying that like it takes a lot of work. And while I think the ACT framework is cool, this is so much cognitive load to just be constantly thinking about like, this is what I'm targeting. I'm watching the patient. I'm looking at their impairments. I'm making adjustments. I'm doing the appropriate amount of cueing. And on top of that, I'm regulating their feelings. And then on top of that, I'm regulating my feelings. Well, I shouldn't say we're regulating each other's feelings. We're helping them kind of move through their feelings and we're moving through ours. Like that is so much mental work. It's exhausting. But I think that if we can practice it in little moments, it makes things easier. And if for no other reason, then we're like just being okay with stuff instead of being like, God, and that session was a total waste. It's like, I did my best and they did their best in terms of what they could bring to the table. So like, everyone tried. Good job.
Good job, team.
Good job, team. That's right.
Oh, the people in my head.
Okay, so does the whole river and rock thing make more sense after this 40-minute discussion?
It does, but I can't stop thinking about how smooth the river rocks are and how much the river changes the rock over time.
Yes, by flowing around it.
So, but like, that's what I keep thinking. When I think about the river and the rock, my immediate thought is this sharp, jagged, big boulder. And then my second thought is little pebbles.
You know what? I really like that in the metaphor, you know? When the rock starts in the river, it's all jagged and stuff, but over time, it will become a smooth, pretty pebble.
We will wear you down.
That's exactly what I tell my patients when I walk in the room. Hi, I'm Eva. I'm here to wear you down. And you guys can try it too, listeners. Just look for moments of inflexibility, a moment when you or your patient are like really fused with their thoughts. You're not able to like kind of get out of a rut. And try some of these for our clinical recommendations this week. Notice a moment when you're like, feel like you're pushing and ask a values-based question. Share this episode with a colleague so that we can have more listeners.
And then talk about your small wins with your friends, about how together you are both avoidant to your one patient and how each of you had overcome something. And then give each other a cookie for doing your darndest.
That's right. And you can be like, you know what? I'm a good colleague. And they're a good colleague because we gave each other cookies. See, we're all ACTing all over the place.
Until next time, be more river, be less rock, y'all. Thanks for listening.
Bye.
You've been listening to Speech Talk.
Thank you, everyone, for coming to listen to our research book club. Until next time, keep learning and leading with research.
If you like this episode and you want to give us some love, please rate us on your favorite podcasting app. Leave a review and tell the world, because as podcasters, our love language is in positive affirmations.
And if you like listening to us, you may like more podcasts from our network, Human Content, like How to Be Patient, Bendy Bodies, Knock Knock High with the Glockenfleckens, and Psychiatry Bootcamp.
If you have a research topic you want us to cover, or you have episode comments, clinical experience you want to share, or just want to send us some love letters, send us an email at hello@speechtalkpod.com.
If you want even more Speech Talk content, check out our website at speechtalkpod.com, where you can find all of our resources we made for you, copies of articles covered, and Eva's blog following these topics and more.
We're your hosts, Eva Johnson and Emily Brady.
Our editor and engineer is Andrew Sims.
Our music is by Omar Ben-Zvi.
Our executive producers are Aaron Corney, Rob Goldman, and Shanti Brook.
To learn about Speech Talk's program disclaimer and ethics policy, verification and licensing terms, and HIPAA release terms, you can go to speechtalkpod.com/disclaimers.
Speech Talk is a proud member of the Human Content Podcast Network.
Ready or not, summer is coming, and Wayfair's Memorial Day clearance is on now. Right now through May 25th, get up to 70% off everything home at Wayfair. Plus, score amazing doorbuster deals all sale long and surprise flash deals on Memorial Day. We're talking thousands of products at every style and budget. Now is the time to save big on must-haves for your patio, backyard, and beyond. These savings won't last, so don't wait. Shop Wayfair's Memorial Day clearance now through May 25th.
Wayfair, every style, every home. Mom, can you tell me a story?
Sure. Once upon a time, a mom needed a new car.
Was she brave?
She was tired, mostly. But she went to Carvana.com and found a great car at a great price. No secret treasure map required.
Did she have to fight a dragon?
Nope, she bought it 100% online. From her bed, actually.
Was it scary?
Honey, it was as unscary as car buying could be.
Did the car have a sunroof?
It did, actually.
Okay, good story.
Car buying you'll want to tell stories about. Buy your car today on
Carvana.
Delivery fees may apply.